the word to Professor Azzolini for starting the scientific session about cooperation in e-health and digital health. Professor Azzolini, please.
Thank you, Francesco, for inviting me here another time to moderate this session. You asked me to make a little introduction, and I will do. And we all know that telemedicine is a word with many meanings. Telemedicine means administrative procedure, wearable devices, hospital territory integration, physician to patient teleconsultation, physician to physician teleconsultation for the benefit of patients, help to developing countries, and so on. One of the topics is telemedicine and war. And I have experience on this because in 1996, in post-war Bosnia, we had a direct telemedicine channel between my hospital, at the time hospital, and Sarajevo, with the aid of the satellite of the European Space Agency. And believe me, it worked. It worked very well. The other topic is international cooperation among countries. Architect Saporito founded OCCA, affiliated to United Nations, and he keeps working on this direction very, very well. So I think that the key words of this session are telemedicine, war, and cooperation. Let's start with Gianni Pellicanò from the Neuroradiology of Careggi Hospital in Florence, speaking about the experience of telemedicine and its cooperation between Italy and Ukraine in this terrible year.
Thank you, Mr. Chairman, and thank you to Francesco for his efforts during this year. And I tried to share my desktop. And so I would like to thank everything and to stay with us today, just 1 year after the previous webinar, in which we spoke about the problem of the Ukrainian war and in which way telemedicine could help these people. Just a few words about the situation now. You see here how many hospitals are damaged or completely disrupted in the war, and another problem is that 5 million people left Ukraine to go to Poland, and other million people, 7 more or less, are displaced temporarily in their country, moving from an areas to others. So a very incredible health emergency. In this situation, we try to help these people. But some crucial point I would like to share with you. One of these, speaking about informatics, many journalists described the invasion of Ukraine as the TikTok war, the most internet accessible war in the history, and the most viral social media war. What are the consequences of this? We can have 3 significant digital trends. The first is very important because technological innovation helped Ukraine to offset Russia's Russian conventional military advantage. It means that it was an increasing of participation of ordinary citizens. And so these citizens are have become involved in a digital war fighting. But there is no law to understand some rules in this new type of war. And the third, but not many less important point, is that in this way, this conflict has generated a massive amount of data that are potentially useful for holding war criminals to account. But on the contrary, this proliferation of open source investigation created a new risk for analytic bias and the procedural inconsistencies. We try to help these people. We, as the Italian Association of Informatics and Telemedicine, try to help moving and sending to these people a lot of radiological instruments. This is my field. I am neuroradiologist, so I try to send with a lot of my colleagues some type of portable CT, ultrasound, and more the X-rays apparatus. We have had, of course, the help of the most important industries in the radiological fields. So we were able to send a mobile CT, and the problem was not to send the material. We have had connection in Ukraine to send this a lot of this material, but the problem was that we need not only to send the material, but to make this material working. So we need ultrasound, for instance, or X-ray apparatus able to send images through the Ukraine nation. I would like to remember a very curious history. The first situation in which a portable X-rays apparatus was used in a war scene was in the First World War from this important woman. He is Marie Curie, very important in our important of radiation and important in physics, and he and his and her husband were awarded by Nobel Prize for this. And she, you see here how she tracks with X-ray, the first X-ray portable apparatus. So it's a very curious that I was able to find this picture in this
1 century
so
after.
This is the yes. 1 century after, we need to we are very sad to say that one century before, we need the same to send these machines in a war scenes. These are X-ray portable machines that are able to transmit and to send images via internet. Because we need to analyze health situation after 1 year in Ukraine. The problem is, this is terrible images. This image represents the Cancer Institute of Kiev, and you see that since it's a very protected place, because there are the nuclear medicine apparatus to radiotherapy, these apparatus normally are very, very protected. It's a bunker, and you see that in this area there are normal people, doctors, nursery, and people with cancer disease. So it's very, very terrible to see all together in this situation. Nevertheless, doctors and the nursery try to continue their therapy. They are preparing chemotherapy in this, you see, terrible situation, because, of course, it's impossible, or should be possible to stop cancer therapy in these patients. Of course, this is the pediatric intensive care in Kiev is completely destroyed. So in Kherson, sorry. So what happened? Our colleague used the CT rooms, the CT suite, to continue the therapy in this very, very young people. It means, of course, that this is not the best area in which we can treat these very unlucky patients, but on the same, side, you see that, of course, CT is not available to perform the images and the examination. This is a new machine to radiotherapy that is stopped, is not working, is completely new, is have never worked because first, there are no more doctors, there are no more nurses. And this is a very special apparatus. So we need to use a nuclear medicine and in radiotherapy. This apparatus, special areas there, because there is a high power X-rays. So it's very dangerous to use without any protection. But even if the men aged between 16 to 60 in Ukraine are not available to go out of Ukraine, and many of them put their family outside Ukraine and then come back to fight for their country. The problem is that not only normal civil people has this problem, but this is my colleague. This is the director of Ukraine Center for Cancer Therapy. This is a lead of anesthesiology in this hospital, and now he chooses, of course, to fight for his country. So it's not available to treat patients. Patients that in many cases have to move, I say before, also inside Ukraine toward a more safe place, if any there are. And so we have to move and to transfer patients in any way it was possible. So a very critical situation. And this is, as you see, an ultrasound machine that we need, that we send to Ukrainian doctors. But once the examination is performed, they need to send to other doctors. And this was possible also not only with satellite, but with a very simple system of any other information transmission, as you see the military army that is trying to use this network system. And another crucial point is that you see how the military people is training to use ultrasound. It's one of the most easy radiological machine that we can use, but it's not so easy to use and especially to interpret. So this the training of military people to learn how to use ultrasound. So telemedicine from the start of the war was the most important challenge that everyone understands that can be useful for the Ukrainian crisis. But one of there are a very lot of companies that offer their platform based in outside of Ukraine to have a consultation for many cases. But some problems are very important. First of all, the languages. It's very difficult to have Ukrainian speakers or Russian speakers to have to make this platform available. This is Viveo. It's 24 hours and 77 days a week available for help patients from Ukraine. Also is a very simple system offered by Israel. You see ultrasound performed using the iPhone. So in the same machine, we can say the medical apparatus and the transmission apparatus, if it work. And you see that how many type of very and portable apparatus were offered to Ukrainian people and then offering not only the machine, as in this case, but also the analysis of the imaging outside this country. And we have a very long list of platforms that try to help Ukraine with the telehealth system. But a very important research was performed in the last month. We tried to speak with a doctor in Ukraine, and we asked them in which way telemedicine could be I can't say a solution, but a big help for them. You see that the most higher number of doctors using telemedicine are general practice practitioners and internal medicine doctors, and you see that how the medical specialties are involved in this field are not more. This is the analysis of the percentage of telemedicine in their clinical workflow during war, and the numbers are good. In which way they use the telehealth services? First with smartphone, and it was quite obvious. Then a laptop, PC, also the simple pulse oximeter, and the tablet, blood glucose monitor, the simple telephone system, the peak flow meters or spirometers that are the system that the Ukraine doctors are using in this moment. And in which type of technical solution? They use normally the instant messaging apps. So it means that a simple SMS, a simple WhatsApp could be very useful to send images, or a phone call, you see, video meeting apps, email, SMS, and telemedicine software platform are, of course, very low now. And Ukraine is not a country far from us; is Europe. So it means that we have the war in our countries, and Ukraine is not so far as Afghanistan, as Syria and others. Is a very important and crucial country where many people, especially young people, are involved in their government. And as Mikhailo Fedorov says, not less than 1 year ago, is that the Minister for Digital Transformation in Ukraine is a very active man, is a vice president of the vice prime minister. He say that here he is creating an information technology army because cyber war works better than bullets. So it means how the information technology is crucial in this war. And for this reason, just a few slides to remember how this war is led by Russian against Ukraine and what are the consequences. Russian cyber operation against Ukraine increased during the time, and you see that the day of the Ukrainian invasion, we have the peak of this operation against the Ukraine. And just to remember that there are the hacker groups has FIN12VU, that is a Russian-speaking cyber criminal group that targets hospital and healthcare, normally in across North American, using ransomware. So they collected a lot of money, but they are not only the same as this Ryuk that is able to identify and encrypt the network drives and the resources, and is able also to delete the shadow copies on the endpoint. The attack on the health system means suspended surgeries, delayed medical care, and the loss of $1 million. Another group is the Conti RIS. The Conti RIS announced exactly the day after the Russian invasion that it was supporting Russian and the Russian people. So another group that is the health system. But an Ukrainian nationalist member of this group leaked internal chats, source code, and stolen data in retaliation. So you see how this war is not a military war, but is a very cyber war. On the contrary, the Anonymous announced in the days that they would be launching attacks against the Russian government. So these are a sort of two different armies, not with bullets, not with weapons, but only with cyber war. The consequence: hospital and health system may be targeted directly by Russian-sponsored cyber actors. Second consequence: hospital and health system may become incidental victims of a Russian-deployed malware or destructive ransomware. And third, a cyber actor could disrupt the hospital services. So, in conclusion, you will see that how many initiatives we have, but we have to coordinate because it's very difficult in this situation. There are a million people moving from outside this country, and it means that the people, the countries that are hosting these people that are moving from Ukraine are in very enormous difficulty. And I just want to remember what happens in Poland. All the citizens coming from Ukraine were considered as Poland citizens with the same facilities for health system, and so as we can say that we were considered Poland citizens. But this was not the same for people coming from other countries in Poland. So you can imagine how this situation can create other difficulties. So we need to combine our efforts, and we have to analyze every day, every weeks, the current situation, and to understand in which way you can develop effective steps to solve so many problems. So telemedicine as an immediate solution with a rapid increasing of the demand of service, but on the contrary, this solution is very difficult to use since the fact that the Ukraine is a big country, and there are a lot of connecting difficulties, and we don't have to forget that we move data, and for this reason we know that use of telemedicine in this war theater is very difficult, because we have to put much more attention to so-called privacy or security and safe way to move this important notice than in other country, than in other situations. So first of all, we hope that this war will stop as soon as possible, even if I think that it will be very difficult. And so for this reason, we need to help these people independently. That was our political ideas, because we have only people that is suffering and must be helped from us. Thank you.
Thank you very much for this presentation. I have a little question for you. You worked on sending in Ukraine neuroradiology treatment instruments, but what about the skills and knowledge of physicians in Ukraine now? And you told that it's convenient to have a physician-to-physician teleconsultation, of course. we found a telemedicine platform for this on the web. Do you think that a platform on the web could help the link between Ukraine and Italy with many advantages, I think?
Of course, absolutely. Because as I told you before, I think that it's not easy, but it's possible to send machines.
Excuse me, the problem is also the server, maybe.
The server, yes. The solution that you propose on the web, I think that could be the most easy and the most affordable, because the difficulties that we have experimented was exactly to send the images, and not only because in many cases these machines are not used by doctors. Okay. So it's a simple sending of images that must be interpreted and must be seen by doctors. No, so this could be a solution to have or to move over the difficulties to have machine in a war field and to have the doctors that can read these images. So far, it means that in this way, also outside Ukraine.
Thank you and congratulations for your work to Ukraine. And may I ask to Wojciech Glinkowski to speak?
Good morning.
So we will hear you.
I'm listening to all the
Okay.
presentations since early morning.
Okay.
Morning.
I will hear you.
I'm very pleased to
Telemedicine
be
in
here
Poland.
among you.
Ciao, Wojciech.
Thank you very much. I would like to co-present somehow to the previous presentation. That was excellent overview and introduction for my tiny input. And I would like to present two different topics. At the beginning, will be the very short presentation. The presentation one. Can you see my slides? I hope. I'm sharing the slides. So the first part will be.
We can see your slides.
Okay.
Can you see the slide? The next slide.
Yes.
The title of initiative.
Yes. Thank you very much.
I would
Thank
like
you very
to
much.
follow James Goldberg introduction with an initiative to increase the recognition, impact, and visibility of IMIT conferences. So it's already the sixth one, and we should do the best to be visible better than before. I would like to show, and we should like to show the increase of international attention, the visibility of the efforts, initiatives of IMIT organizers, in particular initiatives of Professor Sicurello. So these initiatives should include local activities, individual participants and their involvement in the thematic and professional groups, and the websites. For example, the Polish Telemedicine Society is posting the information about the webinars and the conferences organized under the umbrella of IMIT. And we can also inform the social media, the LinkedIn, Facebook, Instagram, and other professional groups, wherever you are involved. And I would also suggest to be more scientific with the participation and publish scientific papers appearing in highly impacted journals devoted to telemedicine and medical informatics. There is a list, the short list. Of course, there is not the full list of journals what I can propose, but the Journal of Telemedicine and Telecare, Telemedicine and eHealth, Telemedicine Reports, or the International Journal of Medical Internet Research, and other journals from broader interests, for example, International Journal of Environmental Research and Public Health. They are keen to open the special issues. Maybe we can together ask for a special issue opening for topics and presentations prepared as articles in this in special issue. If there's discussion possible to be opened, then please discuss for a short moment about the initiative. If we want to discuss later on, then I'll turn to the next topic.
Thank you very much. It's one important topic to increase international attention. You spoke about the high impact journals with an impact factor between 2 and 7 about Journal of Telemedicine and Telecare and others. But which is, according to you, the matter, how we can improve more and more this visibility, because this journal are for a little audience. You know what I mean? How we can improve the visibility of these important journals? How?
These journals are more popular due to the pandemic. They raised
more popular for us doctors, not for people.
For other people, but scientific impact is also important because we are directing our thoughts and initiatives mostly to professionals, to the public. Making the more interest with the public, we can organize some promotion on Facebook or other social media. It is way open to do so, but scientific visibility should be considered as important for us.
I published on Journal of Telemedicine Telecare, and it was easier to publish 7 years ago, 8 years ago. Now it's not so. Now it's quite difficult to publish on the journal because of peer review process are very strong. Maybe could be better if these journals published more easier our efforts.
The last point was the journal of what I told in the on the last slide.
Yes.
What you could see.
Yes, I would like to ask a
International
question.
Journal of Environmental Research and Public Health. It's a quite visible journal,
Okay.
but it is connected with the payment. So it's open access, so the payment should be done. But we can get the special issue just devoted to the topics we are discussing during the IMIT conferences.
Yes, can I ask you a question?
Yes, please.
Yes, thank you very much for your presentation. I gave just an introduction in the first part, but I would like to ask a specific question. For the last 10 years, 15 years, we're able to use innovation simulation direct to do surgery and to look at different images. The telemedicine and telesimulation is direct and has been shown for the last 10 years. Are we using this today? Are we able to use this today in the context of Ukraine, in the context of countries that like Turkey who have had earthquakes and have difficulties? What is the state of using simulation technology so that we can help the doctors, help the nurses and the professional people to aid the patients directly?
It's a very good question. I think we should look for a very specific problems that can be solved in a simple way. I would like to present the second presentation. What I would like to propose very tiny topic, but very specific with a fracture healing monitoring. That might be the solution for a future. It is based on already published and practices, and you'll see. Okay.
I believe, thank you for answering, but I believe the question touches two specific important initiatives that we have to do. That is to identify really the level of education and formation that has been given to the people that are using this technology and how they use it. And secondly, to identify and evaluate with them without being critical, their needs, the use of the materials, and the specificity of changes that are necessary to make the efficacy, the quality and security and real use of this material to be very profitable for everyone.
This is correct, and we need to look for partners from Ukraine to discuss these topics and look for a very specific issues. We can work together with them to help them and make them satisfied with the solutions we can together elaborate.
Thank you very much. Thank you very much.
Okay, last comment. I did not see again a special number of telemedicine telecare or another journal completely dedicated to telemedicine and Ukraine. Maybe it could be useful. Okay.
We need to contact the editorial board and of each of the suggested journals and discuss whether it is feasible to publish such a special issue.
Yes.
Very nice. Sorry, very nice, because Ukraine is a very long history of telemedicine application. I have in my home a book of the history of the Ukrainian telemedicine. We can publish some photo of this book. I received this book from my colleague from Ukraine. You remember Wojciech during the first IMIT conference.
Your colleague Vladimirsky.
Yes, in Geneva. Thank you. Thank you.
He's also an orthopedic surgeon. Then I'm proud of his specialty. And as I knew, he moved to Russia a while ago, but I don't know what is he doing right now.
I think in Russia.
Yes. Okay. So may I turn to the second presentation?
Yes, very shortly. No, Claudio, c'è una seconda presentazione.
Okay.
Okay.
This one will be the practical topic, and I would like to present the combined technologies of virtual fracture clinic and remote assessment of fracture cases and telemonitoring of fracture healing. So the virtual fracture clinics are the new service designed to speed up the access to orthopedic trauma care. They are organized in several countries from Australia, UK, Netherlands. Also, I've heard about the Italian services also. The number of publications raised recently from 2000 until today to over 500 publications in the PubMed. So I think it's worth of interest that traditionally all patients who sustain a broken bone are given an appointment to fracture clinic. This often happens in a day following the injuries, and then they are distributed to several services like emergency department or 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 rehabilitation. So the virtual clinic integrates with existing IT systems and means the patients and clinicians can interact digitally instead of personal, face-to-face. In several surveys, at least 60% of patients who used virtual care tools said it is particularly during the pandemic, they want to use again such a technology, and as an option for several patients. So in a scheme, there is attendance in the emergency department, and then the patient can be safely discharged, or the images mostly of the patient are reviewed by orthopedic team in the virtual fracture care. Then the patient is distributed to the specialty clinic or the physiotherapy or discharged with phone discussion. So virtual fracture clinic is able to assess the fracture healing status and make the visit face-to-face unnecessary. In demanding cases, the formula of the meeting can be switched back to face-to-face. There are several papers about that, how effective it is, how time effective, and then we can look at them and confirm some advantages of organizing such virtual fracture clinics. Having some legal aspects already elaborated by the British Orthopedic Association. So the aim is safe patient-centered self-care with a patient empowerment model, with an appropriate referral pathway to emergency and accident departments, and also supporting and still combining with traditional fracture clinics resources. They are again utilized when the patient needs that. The connection between the virtual fracture clinic and mHealth can be achieved by the applications. This is one of the applications operated together with the OLVG clinic in Amsterdam. I'm going to visit this clinic next month and see how they are managed their own cases. And in the virtual fracture clinic website, usually some information for the patients are available, how to manage the acute injury, how to drive, how to take care of the deep venous thrombosis and thromboprophylaxis, and also the contact box. Also, the National Institute for Health and Care Excellence in the UK developed some research recommendations, so we can also be safe having such an initiative. So the international discussion is needed, how to use the abilities of the virtual fracture clinics during the mass injuries events, the war or earthquake, or other mass injuries. So it has to be elaborated locally. My previous several studies were focused on how to improve the evaluation of fracture healing, how to make it measured. So it is based mostly on the images, because the picture speaks louder than 1,000 words. And if we can measure it, we are closer to final monitoring of the healing. We can use some clinical criteria to define fracture union, including the physical examination, but also radiographic criteria we use, and we can also implement some evaluation based on the images. So the radiographic criteria are quite important. You can see the fracture healing in two different bones. On the left side, it's a humerus. On the right side, it's a non-operated clavicle. So the X-rays, even non-digital, can be digitalized and then reanalyzed together. Of course, not by the Photoshop, by the other software. We can utilize also the ultrasound. The image of the fracture healing can be also practical, and with the portable devices can be easier to access, or we can also measure the transmission of the ultrasound through the fracture gap. We can also do some bone density evaluation and draw the fracture healing curve that will allow us to tell, is the patient already healed or not? Is the patient already able to take the load on his bone, particularly in the lower extremity, or not? So with the analysis system, we can also evaluate it more feasible and better, and working together with the virtual fracture clinic and some support with the healing assessment supporting application, we can get the even better results, particularly that applications are able to operate in several languages. So the future development, orthopedic intelligence, because we called it orthopedic intelligence, together with the VCF, can be implemented quite well. And both virtual fracture clinic and web-based decision support systems can supplement each other with the remote diagnostic for fracture qualitative and quantitative evaluation and monitoring of fracture cases. Thank you very much for your attention.
Thank you very much for this explanation, which was extremely pertinent and extremely clear. Well said. A picture is worth 1,000 words. We agree. I would like to just suggest one thing. That is, after we have both worked in this field for many, many years, perhaps it is very important now to have people locally, regionally, and nationally identifying the patients, the number of patients, and the number of success, so that all of your information and all of your formation and all of this effort for communication is understood in terms of data of population utilization, population effectiveness, population recommendations. And that requires that the people that are working in the local areas identify people that can take the data, make sure that the data respects everything that you just tried to say very clearly and said very clearly, not only tried, but said very clearly, and use our systems of education, communication, so that we can have the feedback necessary to understand exactly the number and the demonstration. Thank you.
Thank you very much.
We need to have people in the local area that send us information of how many patients are using this materials, how many patients or how many people are not using, and how we can change the numbers to use these excellent resources.
That needs cooperation, and this is a main call for my presentation. Then we need a cooperation, because it is
remarkable.
Single initiative. It's a call for cooperation.
Okay.
Thank you, sir.
Thank you for your presentation.
Thank you very much.
And we have to proceed. Next speech by Mauro Giacomini from Genoa, Italy. He's speaking about digital health and medical informatics Europe conference.
This is a presentation set up with the help of the colleagues of Italian Society of Medical Informatics. As you know, in Italy, we have some medical informatics society. ITIM is one well-renowned, and with other colleagues in some years ago, we would like to set up another academic medical informatics society connecting to all people that are teaching this type of subjects in our universities. And so CBIMS, Italian Society for Biomedical Informatics, was founded in 2016 with the help to connect all these people that are coming from different scientific groups together in a unique society, mainly to contribute to the European effort towards medical informatics. As many of you probably know, in Europe, we have a European Federation for Medical Informatics called EFMI, which was founded in 1976, so it is far longer than CBIM, because in Italy we had some difficulties and some many different associations that grow up and destroyed and similar things. So we had to set up just one specific academic society to contribute and to be present stably in EFMI. Because why we would like to stay within EFMI? Because EFMI has a great, very important objective in this foundation. That is also important in this context to advance international cooperation and dissemination of medical informatics within Europe. And we would like to promote the standard application of medical informatics and to promote a standard education system in medical informatics. So this is the reason why we decided to define an academic society to be connected to EFMI. As you can see, nowadays we have 32 countries that are contributing to this European Federation. And as you can see, we have also, of course, it is very spread in Europe. Both Western countries, but also Eastern countries are very well represented in this federation. And also we have both Ukraine and Russia, and with good scientific connection as well. So we would like that sciences can help to promote such a sort of dialogue between, or at least at scientific level and academic level. We would not try to cut the connection also with Russian colleagues in this respect. What are the work, how the work in EFMI is organizing? Mainly through specific working groups. This is a list of the working group at present active in EFMI. If you can see, there are many of them are some historical ones, and some are also quite new. For example, the Fair Data in Health Research Performing Organization. It is a very recent working group coming out of a very successful European funded project, Fair for Health. And also we have an interesting young EFMI group to improve connection between PhD students, postdoc students, all over Europe in order to set up a more linked cooperation and more stable connection, also against this very sad problems we had in this period. Another very important work within EFMI is to dissemination of knowledge, and it is done through specific journals and conferences. We are supporting, we have not one official journal of EFMI, but we are supporting the main health informatics journals present in the community, and the three major ones listed above: Applied Clinical Informatics, International Journal of Medical Informatics, and Methods of Information in Medicine. These are the journals specifically supported by EFMI people, with EFMI people inside the editorial board. More specifically, EFMI organizes yearly conferences, and starting from Medical Informatics Europe conferences, which is the main work done by EFMI, and it is now we are in the 33rd conference. It will be held in Gothenburg, Sweden, from 22nd to 25th of May this year. But also, more recently, EFMI has set up two other more strict. The MIE is a very large conference, very good for having good connection and similar, but not to go in deep with the topics. So we had the idea to set up two other specific topics conference. One with different topics changing each year, and it's called a specific topic conferences. This year we are organizing in Turin as CBIM, a telehealth ecosystem in practice. So a very good, and we would like, of course, to invite people from IT, but also people from all over Europe that are working on these telehealth and telemedicine subject to join us in this special topic conference in Turin in October. We have to define exactly the date and the venues, but we will go out with the call of paper in a few days, and we will have, it is also every year, and this is the 15 meeting. We have the personalized health conferences, the so-called P-Health, founded and directed by Professor Blobel since the first year, and we will have the P-Health conference in Wien in December 2023, and also the call for papers will be ready soon, and I will distribute to Francesco, and Francesco can distribute to all friends in this group. And we would like to, all these conferences are peer-reviewed conferences, so the proceedings are published in iOS and are also present in Scopus and in PubMed. And among these proceedings, we are selecting every year some excellent work to be that are important, and we would like to have extended version of these papers to be published in the journals of supported by EFMI. One other thing I have to enlighten to people, maybe if there are young people attending this meeting, and also from Eastern country, I would like to set up, and we have special also special fee, of course. All these conferences and journals have fees to be paid everywhere, but in FMI we have special interest to have interesting young people joining us, and specifically also people with specific problems like the ones given by war, and we set up specific supports for this person to join us, both in conference and in publication. Thank you very much for your attention.
Thank you. May I ask you, is Italian Society of Biomedical Informatics growing up with the help or together with a group of physicians for advices, users, needs, or is it growing up with the physicians from time to time, depending on the projects?
Yes, the society is specifically connected with our scientific, academic scientific groups, like the bioengineering, the informatics, and electronics. So these are the society are doing with just with people, but of course we are a structural connection with a group of physicians in order to define the correct questions to be asked to the technology part, because we do not like to set up technology tools that are not useful for medical people, and so we are and also we do not in Italy, we do not, as we know that there are many conferences organized by IMIT, we do not organize since now Italian conference of CBIM, but we are working on this type of connection with other Italian scientific society from the medical side.
Thank you.
I have a short question.
Any comment, question? Yes.
Thank you. Remarkable presentation of the EFMI journals and conferences, which are pertinent today and continuing always, and being published in PubMed, National Library of Medicine as well. I was not aware of that. I would like to, my question is, all this information is extremely important. How can we make this information useful in education, and how do we measure all these conferences and how they're integrated into the educational programs of the professionals that need to use the information as it's being created, generated, and implemented? How do we use a connection with the education resources to know exactly how these conferences are being integrated into our education system at all the levels for all the professionals?
Okay, very good question. Specifically, we have one working group on this education topic within FMI, and we are working on this topic. And last year, unfortunately, we had also efficient in the dissemination. Last year, we had a special topic conference in Cardiff on the setup of new education system for medical informatics in connection also with medical society, because as you know, in Italy and also in Europe, there are some experiment of joint education between technological part and the medical schools. And So it was discussed in Cardiff last year, but the work within educational working group in EFMI is still working up, and we can be in contact and set up perhaps the working group leader in EFMI is Professor John Mantas from Athens. And so we can be in contact and to set up new ideas on this topic.
Thank you very much for your consideration.
Thank you, Professor Giacomini.
Thank you very much, Dr. Francisco, and my session chairman, Claudio Azzolini. Been listening to the nice speeches by the senior medical practitioners. I'm not a medical practitioner in that sense. I teach computer science. My interest in the practice of medicine is primarily because of the applied research in INDIC technologies. We have been looking at healthcare and how to bring technology in a manner where it blends with what we do in India, INDIC traditions. So the schedule is out here. I begin with a simple narrative about William Harvey, who was the chief doctor to King Charles I of England. When the Civil Wars broke out, Harvey accompanied the King's army to the first major battle at Edge Hill on 23rd October 1642. During the fighting, Harvey was in charge of looking after the King's two children, Prince Charles, 12, and Prince James, aged 9. Harvey later told his friend from Genoa that he sheltered with the princess under a hedge, taking a book out of his pocket to read out. A bullet of a great gun grazed on the ground near him, which made him move. The secret of the heart, thanks to William Harvey, was no longer known to God alone. The language of excellence has always been quaint, and it's very nice reading this. A bullet of a great gun grazed on the ground near him. The secret of the heart was no longer known to God alone. Life was no longer a spiritual matter, but could be determined experimentally and rationally in terms of flesh and blood. That's the beginning of the modern medicine. And I picked notes from a nice book, Medicine, from Hippocrates to Gene Therapy. The discovery of circulation of blood by William Harvey marked the beginnings of modern medicine. Book, 1628 book is well known. But what is striking is William Harvey used a method introduced by Galileo in the new physics. Blood travels centripetally, and that means they converge into the heart. Wherever they go, that circulation model envisaged by Harvey makes everything get into the heart. He applied mathematics to medicine, the very first to apply mathematics to medicine. He introduced measure in the study of the body. Harvey accounted for one anomaly: why did poison kill so quickly? Great answer for that anomaly, but then I am inclined to think that his concern about the foundation about the circulation model is to mitigate the toxic effects of the wounds, poisons, rather than the way in which we will have to progress in making preventive functions of the blood happen. Finding a reputable complementary medicine practitioner, William Harvey also believed in witches. At the request of King Charles I, he gladly agreed to examine a suspected witch. Harvey also frequently remarked that Europeans know not how to order or govern their women, and that Turks are the only people who use them wisely. The man was not a feminist. He was not a feminist. So based on these observations, we have a strong reason to believe that we can take a look at alternative medicine and see what happens if we slightly move out or work around the Harvey's model. Alternative medicine is a broad term encompassing a variety of medical modalities. I'm not going through these definitions. My apologies, the typo here. The concern here is that allopathic medicine needs a strong statistical evidence-based in a mainstream medicine. Alternative medicine is any practice that aims to achieve the healing effects of medicine despite lacking biological plausibility, testability, repeatability, or evidence from clinical trials. So therefore, we don't do anything in alternate medicine. If it heals, it heals. So therefore, we need to see how we can have an integration across this. But before that, common concerns of doctors about complementary medicine. I've been interacting with a lot of medical professionals. Patients may see unqualified complementary practitioners. Patients may risk missed or delayed diagnosis. Patients may stop or refuse effective conventional treatment. Patients may waste money or ineffective treatments. Dealing with interdisciplinary issues with complementary practitioners. A little later, I'll come to that. What is that interdisciplinarity? Consider asking about complementary medicine use when patient has chronic or relapsing disease. Conventional approaches require maintenance treatment. Patient is experiencing or is concerned about adverse drug reactions. Patient is unhappy about progress. There is unexplained poor compliance with the treatment or follow-up. Every war has left deep scars. There is no solution. War has happened. I'm not into the politics of the war presently happening, but I'm happy to note that Ukraine is with the United Nations, and I have no reason to think that the concerns about mitigation of war are to be dealt with both the hands that really caused the bang. That's both Russia and Ukraine. I leave it to the eminent scholars here, eminent medical experts. Medicine knows no bounds. Medicine knows no reason to think about all these things, but there is a reason to think that it takes two hands to make the clap happen. On January 3rd, 1657, at the age of 79, William Harvey died of hemorrhagic stroke. One of the worst setbacks Harvey experienced concerned the loss of a great deal of written work when parliamentary troops ransacked his house in Whitehall in 1642. William Harvey did something interesting. He tried to force blood in a vein down the forearm, but no avail. When he tried to push it up the arm, it moved easily. Harvey had proved that the venous blood flowed into the heart and that the body's valves in the veins maintained the one-way flow. So he was taking care of that anomalous condition. A wound should not have serious repercussions due to the toxics. And as we keep telling, the immediate need, a tetanus toxin or even a penicillin kind of a thing, the blood circulation model of Harvey is largely to mitigate that condition. A war condition is that way, wounds. Harvey's case, Harvey describes a case dangerously wounded here and left for dead amongst the dead men. Strip, which happened to be the saving of his life. It was cold, clear weather, and a frost that night, which stopped his bleeding. At about midnight or some hours after his hurt, he awaked and was fain to draw a dead body upon him for warmth's sake. That's the condition he's addressing. And his circulation model is something which needs to fit into that context. So then I talk about the hypodermic needle, which was nicely created to reduce the impact. I'm a diabetic and I take 10 milligram insulin at night. So I keep observing what exactly is that needle doing. I do that myself. All kinds of technology, implants, cyborgs, humanoids, human body modeling techniques, and last but not the least, AI and big data next session. So what I'm thinking about is a hypodermic needle model of what we talk about information. And it's a magic bullet theory. An international cooperation in medical informatics may be needed here. I make an appeal to the elite audience here. Kindly consider this. It's a theory of mass communication, stating that media are able to influence audience opinion to the messages that reach individuals personally. More specifically, the theory posits that messages are able to hit individuals directly and personally, like a bullet penetrating into a person's body. After penetrating the body of a receiver, the message is able to cause immediate reactions. So this is something which we need to add on in our arsenal in managing the medical informatics. It is a mass communication, but it reaches the individuals personally. That's something which I've been working on. And medical humanities, it's all about embracing entanglement, taking risks. Again, international cooperation is necessary. Honoring art and humanism in medicine, using both sides of the brain, medical and humanities. The Indian classical dance, a sacred art. Is Indian classical dance a sacred art? A great many people tend to assume the temple origin of the dance ensures that a sense of the sacred and a link with religion continues to shape its practice. In this brief paper, however, the author rejects this position, arguing that Indian classical dance has not been a sacred art for well over a century due to the process of modernization it underwent throughout the 20th century. So these are certain debates. It's just a question mark. So what happens if that sacredness or religious affiliation is removed? It's a bigger question that we need to answer. So in all these cases, there is something called a medical humanities. It's a nice journal. I keep reading it. It comes and it's all about how the human body is equipped, implanted, connected to vast technology all over the globe. It's global. So what is the concern here? The complexity of cooperation. There's nothing called local in that sense of local. Everything is global. So I had a research scholar who worked on agent-based models. My very first research scholar PhD thesis. This I would strongly think will help us understand in the space of technology, there is no point in surveillance. There is no point in tracking. There is no point in creating all those sensing rods which see whether electronics is there or not. Let them be there, let them happen. They're all among us. I understand the case of airport, that is fine. They're all flying somewhere in the middle. Sensitive places I'm not talking about, but regularly people are people. We don't mind gadgets in any form mingling with us. It's just the case of an agent-based model for competition and collaboration that we need to look into. And the proportionate deterrence, a model nuclear posture review. This is something which I pick up from the Carnegie Endowment for International Peace, the good report, 2021. Personally, I had been with the Halden reactor project Norway, worked with Jackson, Jokstad Hakon in 1998. We purchased Picasso 3. It was very nice in extending the entire Picasso 3 to the Anna University for research. And we got it at a very, very discounted price through due notifications to respective governments. We had to go through the government channels. Integration of Picasso 3 in control of supervision systems. I would strongly think that it is controllable with a good interface, and it's a user interface management system. Game theory is another option. So agent-based, excellent user interface management system with simplify integration, like something like Picasso 3 for the Halden reactor project, and then the game theory. There are 3 strong suggestions that I have to manage a context where everything is together. Medical is there, humanities is there, art is there. So we need to take something called a humanitarian approach. And so we have been really looking at many things happening simply as artistic expressions, but there may not really be. And into this, we'll bring other aspects a touch later, but international relations on game theory, military game theory. Both are very nice. It's an excellent work. It's referred here, Handbook of Game Theory, Volume 2, edited by Aumann and Hart. Well written, 1994, but it's a very excellent book. Dr. Y. Narahari of IIFC is an expert in this area. He was here with the department. He delivered the endowment lecture, NASCOM high performance computing endowment lecture, ADCOM, advanced computing. It was very nice. We spoke. I worked with him. So how do we integrate this is the question. Again, first informatics, so that we create a one level up on the processing. It's not raw data we are looking at, raw sensory data close at hand. That's not the case. We are only increasing the risk factor by moving closer and closer to the hand with all those sensing rods and the monitoring stations. Suggestions for your kind consideration. A one level up idea called medical informatics, processed information. It's an integration of humanities and arts with science engineering. Idea is good, but then bringing them together is not to be done in such a big hurry. We need to work in silos first, discipline first, multidisciplinary later, interdisciplinary a little later, transdisciplinary. We can't jump whole hog. I do acknowledge that we are now attempting to do many things in a hurry. Italy, for example, University of Calabria, they have been separating the medicine and engineering disciplines outside of drug discovery. The relationship, everything is fine. We can see that logic is the foundation for engineering. We can logically analyze. Teaching logic has seldom been easy. Chemistry is not easily fit. Biology, we still don't know how to fit in engineering. So why are we coercing the practice of medicine with engineering is a big question mark. It took so many years for these disciplines to even connect. And we need not be in a hurry. Psychology and sociology are there, but it's very difficult. So back to blood circulation, Harvey's closed circulatory system. It helps take care of toxic spread of, we used to call it septic. The wound that doesn't heal, it's pretty bad. And for diabetics, it's even more terrible, open wounds. So the Harvey's closed circulatory system is very nice. That model, when it is effective, it halts that. But the Gallen's has some relationship. He drew some lessons, but there are other circulation models which we cannot ignore. And the proof of the pudding, as we keep talking, is the way in which the pulse is read. In India, the pulse is read completely differently. The pulse indicates three major aspects: Vata, Pitta, and Kapha. Agni is an energetic current in the human body. Pitta is Agni. Agni is fire. Vata has more connections. Brahma, the Lord Brahma, the Godhead, snake, leech, Akasha plus Vayu. From snake to sky and the air, I can pick a lot of things from the pulse. A practitioner can pick a leech. Shankara is the Godhead for Pitta, a frog, a crow, a quail. It's all fire. Every day we need fire. The very first statement in Rig Veda is that Hamsa, pigeon, dove, cock, water and earth. If we mix, we get the kapha. Also, pulse has many names. Dharani is also earth. Pulse is also earth. So we keep postulating that the human body finds an echo through these interfaces, Vata, Pitta, and Kapha, right away on the skull, the telltale brain. It tells into the environment to a physician. It speaks. The herbs speak to the physician. Like engineering is a dialogue with materials, a physician gets this dialogue with the nature happening. This is something which needs to be explored. I met Dr. Ramchandran way back in 2001. I've interacted with him, but then I'm not looking at this kind of a nature study. It's more on the ideology of Karl Marx. This is nice. It gives a good intro to the Western medical practitioners as to what is the way an Indian looks at all these things. Well, the nice idea, but it's still what I'm talking about is it needs much more cooperation in Chandas, Sanskrit prosody, speech, rhythm, music. It's also the feet of the Godhead. As I said, the three indicators, Vata, Pitta, Kapha, right on the human mind, are read into the environment by a physician, by a practitioner, by Siddha. And it doesn't require any physical contact. We need a physical contact to limit that this is exactly what is it that we are doing. Speech, word meaning pair, is something that we need to understand, a problem of meaning. I do understand that war gets compounded between Russia and Ukraine because KYIV is not the same as KIEV. The pronunciation is different. The Ukrainians have KYIV, the Russians talk KIEV, and they are separate. And therefore, there's a problem. War precipitates, war compounds. These are the speech commands. There are so many ways in which a machine has different forms, and there are speech commands. We need to be able to make a good active monitoring for all these ideas, which I'm trying to share with the august audience. Gati, for example, in the previous slide, I've been using the term Gati in Sanskrit. Gati has many meanings. It's motion, stretching out, lengthening of a syllable, a technical term. The practitioners of traditional medicine have a way of communicating all these ideas. The Gati on the stretch with prefixes and certain indeclinables. Indeclinable in Sanskrit is avyaya, word which means immutable in all genders, numbers and cases. For example, swar, that is what we talk. The way in which music is built in India, 7 swaras, it's an immutable, it's an indeclinable. So not all synonyms and antonyms, not at all it's about synonyms and antonyms, not at all about thesaurus. It's word meaning pair that has to be envisaged. So therefore, what I'm imploring is we need to have something called a human consciousness and flourishing use of paradox theory. Complexity is not the solution. We don't mind a paradox if it is reducing the bloodshed, if it is increasing the peace, if it is saying that we are not, what to say, deceiving one another for no reason. If that can be assured at the level of informatics, medical informatics is a nice term, then we have to be a progressive. This is my humble submission. Thank you very much.
Thank you. Thank you very much, Professor Gopal, for this interesting and clever excursus from medicine, from complementary medicine, body valves, ballet theory, integrated medicine, and so on. And you clearly show us that we must know the past to take advantage of the future. Any question or comment from the participants?
Yes, I have one.
Yes, please.
Yes. We understand that, first of all, I would like to thank you, and I would like to thank our remarkable moderator who is accompanying all the speakers today. I would like to understand, in a country where the population is almost the most important in the world, how can we measure the impact on the population? All of your remarks were intellectually very interesting, were practically extremely motivating, and were incisive in terms of trying to approach the problems. But how do you measure in your country, where you have one of the largest populations in the world, or the largest population in the world, the impact on the individuals, and how in India do you try to go from your statement, for your presentation, to the realities of impact in health?
May I give the short answer? India is always regarded, and we also take pride in contributing what is called shunya, zero. We don't see all those millions. We will have to reduce this exercise that I've been talking about to zero. And how do we reduce it to zero is the question. We are all well regarded for talking about that zero. And it's also space, that Akasha, one of the elements which I can see in the pulse. I need to pick the person on that pulse and then make it somehow go to zero, shunya. It's possible, it's feasible. That's a single answer which I have. We don't see millions. We don't see anybody. Any individual who needs to be impacted, kindly look at the first suggestion that I'm having in medical informatics. It appears for a mass, but it is directed towards an individual. I would go back to that slide. It takes a bit of a time to get this concept in. Now I am to share the screen. Again, doesn't matter. I'll go back to the screen. This is what is called the hypodermic needle theory. We make millions of hypodermic needles, but then it goes only into 1%. So let me share that. A theory which I've been trying to, is it sharing? It should share. I hope no special effects in the sharing now. Yeah, it shares. My apologies. It's nice. I have lot
Short
of
comment, please.
Yes, please. Shunya. That's my simple answer.
Okay.
So we need to negotiate proof events. Communicating and negotiating proof events in cyber-physical systems is my approach. Thank you.
Thank you.
Thank you. Thank you, Professor Gopal. And we proceed with the last speaker. It is Hariton Costin. Is he here? Hariton Costin.
Yes.
Okay. You will speak about telemonitoring and rehabilitation, please.
thank you very much, Professor Sicurello, and your colleagues for inviting me to say something about applications of telemedicine. Our experience in the University of Medicine and Pharmacy, Faculty of Medical Bioengineering, and the Romanian Academy was for telemonitoring of vital signs, and recently rehabilitation of gait of locomotion. Let's go further. I'll pass quickly. You know very many things about telemonitoring. It is very useful for elderly people for telemonitoring in their houses, as well as for rural poor places where medical staff mainly is missing. And I can stress that almost all medical disciplines, specialties, may use telemedical tools. Yes. Some international projects are very, very known. In fact, I present here a historical perspective of telemonitoring. Epimedics, these are projects for 20 years ago, let us say, 15, 20. Epimedics, Health Service 24 from the United States. I want to, yes. To have, yes. Some medical devices, also rather historical. Code Blue, another famous telemedical project, also in the United States. In Romania, like in many other countries, including Occidental ones, we do not have a national telemedical network eventually for telemonitoring. But we have some specific applications like telemonitoring of patients in emergency medicine. You see, there are almost all ambulances, cars are equipped with telemonitoring tools. But as standalone applications, there are some local implementations of telemonitoring vital signs. I shall briefly present you Telemon, which is our flagship project, funded and finalized with good results, but it is now rather old It is 12 years old. It is a client server project architecture, which now will be replaced by a cloud computing paradigm, as many other projects. So it had a database central server and some local subsystems and fixed local subsystems and mobile subsystems. And of course, this central server had to be accessed by physicians and by ambulance for emergency medicine. Related to the patient, it was implemented a PAN network, personal area network, with medical sensors, but of course a patient doesn't have all these sensors, but the only very needed ones, like respirations, oxygen saturation, blood pressure, why not, and a module for fall detection, which is very important for elderly people. It is known that almost 75% of elderly people every year have at least one important fall. Of course, there are radio transmitters which transmit data to local data concentrator or acquisition module, which in its turn transmits data through internet to the server or to the cloud computing application. Very briefly, just experimental modules, so they do not look nice, but they worked very well for our applications. So ECG amplifier, respiration sensors, yes, this is a small antenna. Blood pressure with the conventional blood pressure monitor taken from the market and completed with the transmitter module. Temperature measurement also very briefly. The so-called personal server, it was a smartphone or a PDA by that time, where some biosignal analysis applications ran. Yes, the data came from the same radio transmitting information. This is a module that acted as interface for mobile phone. And these are some applications for ECG, computing heart rate, oxygen saturation here, and the blood pressure. Yes. Some simple computing tasks, but very useful for different cases. This is a main implementation for the physician application. So the medical staff who access the server and can see the medical data of the patient. Of course, the privacy concerns have been solved. But now I want to stress on some barriers to telemedicine in our days. Of course, the COVID-19 pandemic, unfortunately, improved the telemedical applications. And fortunately, it was a very good solution, even if many legal concepts were not solved some years ago. So, ethical barriers, of course, data privacy and confidentiality issues must be solved. You know, unfortunately, in this time with this war, the medical data of the main actors, like let's say Putin, Biden, Zelensky, and so on, are very important to be known by different third parties. Why not? Some economical barriers refer to telehealth infrastructure. And of course, mainly to personnel training. And here we have a lot of things to solve. Other economical barriers are financial reimbursement and billing for telehealth services. And of course, insurance coverage. A main issue is to solve regulatory barriers, yes. And a very important observation is this: in country without clear legal requirements, the leading medical bodies, societies, medical societies for certain disciplines must regulate, must set up guidelines, yes. And of course, these medical bodies must help authorities to go to. In fact, some 15 years ago already, the European Commission asked to the members to approach these regulatory barriers and to solve the telemedicine problems. But I think nowadays they are not ready. Social-cultural barriers, yes, we know very well that medical staff are often skeptical and resistant to change. Yes. Also, certain populations, mainly in rural settings, may have real concerns about this domain. And the solution is, of course, education, 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 education. Some technological barriers may also or must also be solved, but it is not. They are not the main problems, because now the broadband developed very well. Even 5G technology. And of course, the collaboration between medical and technical personnel staff is also a solution for applications, and also evidence-related barriers. And now the second thing I want to show you is our newest applications for gait analysis in video sequences for limb, for rehabilitation, for limb injuries or some pathologies, some neurological, eventually degenerative pathologies like Parkinson disease. We used an application developed and named MoveNet Thunder. Thunder is a version of this MoveNet pose estimation application. It detects 17 joint position, and from this key markers, we can compute different angles from left and right side. Then some statistical parameters for each stride are computing. Why? To use them in classifications. You'll see immediately which is this classification. In this way, we can compute the degree of rehabilitation, yes, of gait. And the telemedical aspect is very useful trait is that the patient, her or she herself, may take some movies and send them to be computed, to be interpreted at distance, yes, by the therapist. So the patient is at home. Another one takes some movies with the patient walking, and the interpretation may be done at a distance. This is a MoveNet architecture. It's a technical detail. Yes, it is made by TensorFlow platform. It is important. It works in real time. Yes, in real time. These are the 7 key points, 17 key points. This is an application, chronic hemiparetic gait. It is a movie taken from YouTube. The result is her left lower extremity is a half functionally shorter than the right side. And another example is this man with hemiplegic gait. It has some weakness and spasticity with flexion and lower extremity and extension. So This is a table with the three diseases taken into account: hemiplegic gait, chronic hemiparetic gait, and normal gait, single gait, normal gait. Yes. Strides, only 5, 6 in this application, and the total number of frames for these strides. Some parameter computation. For simplicity, we used a single stride and some frames, 30, 40, 70 frames for only one stride. Some angles with normal and pathological numbers, degrees. As classification experiments, we used the famous VECA machine learning, and from this platform we used 3 classifiers: a deep learning, an oldest but goodest, multi-layer perceptron, and simple logistic classification. So we have 3 classes. We used the 10-fold cross-validation for the validation of validity to validate our experiments. And we obtained very good results. Of course, only for 3 classes, 99% for a specific data set. Of course, these results were validated by physicians.
To conclude, please.
To finish, yes? Okay. Some other results, conclusions. We implemented a dynamic evaluation. There are 3 functional assessments during the whole rehabilitation session. We approach different non-neurological impairments, yes, like fractures, soft tissue tears, surgical meniscus, operated meniscus, and so on. Some references. And thank you. And please, I want to make a small announcement. We organize a traditional IEEE conference, EHB, Health and Bioengineering, and in November it will be the 11th edition in Bucharest. We moved from Iași to Bucharest, and this is the website. Thank you very much for your attention, and I hope in a further collaboration within European projects. Why not every year? There are some useful programs, including digital health.
Thank you.
Thank you, Mr. Costin, and thank you, and congratulations for your talk, and also for your next congress in Bulgaria. And you are working on Institute of Computer Science. So I would like to ask you, from the technical point of view, your idea on wearable devices on the clothes to measure many body parameters. I know that Alessandro Orro will speak about that later in the morning. But what about you wearable devices? Are they nowadays enough efficient to be currently used in medicine, not in research? And which one, according to you? Or we need more time, more research time?
As you very well know, an old wearable device is a Holter device for ECG. It's very useful. Its dimensions are very low now. And there are many other wearable and even implantable devices, which may offer good data, including, let's say, for gastroenterology, video cameras inside our body, in stomach or intestine. Why not? These wearable and implantable devices are fed with energy from outside our body, from radio, with radio frequency energy. Yes, energy transmitted by radio frequency.
Okay.
I don't know. In principle, many traditional classical standalone devices may be now made wearable and implantable.
Okay, thank you.